Rupin to start and for people to assemble. Any lingering, burning questions that were not, oh my gosh, okay. Yes.
Can we give the mic?
Microphone to him. Here, you can take my microphone.
Sir, is there any role of testosterone injection in any case of male infertility? So, I want to actually suppose that there is hypogonadotropic hypogonadism. LH FSH are high and intratesticular testosterone is less. So, is that the case where we can go for testosterone supplementation?
Because giving exogenous testosterone will not raise intratesticular testosterone, and therefore there is no role for giving testosterone in a patient who is interested in fertility. If you give it exogenously, it will not raise it. If his testosterone is low and FSH LH is high, that's testicular failure. There's nothing you can do other than a microtest.
He was asking hypo.
No. He said
so
high FSH, high LH, low testosterone.
Yes.
Yes, sir. We know that growth factors that needed for the tissue repair and tissue regeneration. So for that, the options are like PRP and stem cells. So for optimization of this before micro TC, can we consider? And what is the validation? Like any evidence? What is recommendation?
No, excellent question. You want Dr. Vineet really wants to, he takes PRP.
So the evidence does not exist. If you are to use, however, in the form of a trial, understand that we have not been able to, in lab also, modify anything up to the level of, if meiosis has not happened, you cannot modify. So if you are to use in basis of a clinical trial, it is beyond the secondary spermatocyte level, which means if you have biopsy evidence that meiosis has happened and you've moved to hypospermatogenesis or late maturation arrest, you may look at factors in the form of a trial, controlled trial with informed consent with the patient that you're doing such a study. Otherwise, there's been no evidence if you're using it for early maturation before only in the early stage of development, there's been no evidence and no trial there.
So Rupin sent me a paper 2 weeks ago saying, Ranjit, what are your thoughts on this? It actually got published from a Turkish group where they injected PRP in patients with failed microtesy, and they got up to 30 to 40% retrieval rate in the second microtesy attempt. No, please don't clap hands. Rupin asked me the thoughts. I'm sure we are going to hear from him as well. I'm very happy you asked this question. So PRP is basically simple platelet-rich plasma. So for those of you that don't know, popularized as P-shot, used extensively in dermatology, cosmetology, gynecology as well. I have lots of experience in using PRP for erectile dysfunction. We have used it in clinical trial settings. In fact, we published the first paper showing PRP does not work in erectile dysfunction. We showed placebo also improves erectile function similar to PRP. All the PRP companies are very mad at me for showing PRP does not work. Erection is a very simple process. No, it requires some hormones, some smooth muscle, some blood flow. You're supposed to get an erection. If these growth factors can't even fix such a simple process as an erection, how do we think it's going to fix such a complex process as spermatogenesis? So biologically, it doesn't make any sense to me that PRP can somehow stimulate spermatogenesis. In what Dr. Vineet mentioned, if you've already reached secondary spermatocyte and you're trying to put some growth factors and try to stimulate the last 1 or 2 steps of spermatogenesis, maybe stem cells, exosomes, PRP may help. But other than that, I am absolutely not sure. So take home message, you're going to go home and not do PRP. And for patients that come to you asking for PRP, you tell them it will not fix spermatogenesis. And just leave it at that. But Rupin.
I fully agree with you. So clear message, as of right now, the evidence is not there. You had a comment and then we'll start the talk.
I just wanted to ask a further extension. PRP I know might work, might not work. And erection is a mental problem also. 80% of sex is in the mind. So if you put PRP, nothing's going to work. What about stem cell and for early maturation arrest? Has there been any study?
No, I don't think there's been any study on using stem cells. There is a large center in Jordan that has popularized using stem cells. I've unfortunately done microteses after those stem cell injections. It's a huge ball of scar in the middle. It'll take me 1 hour to even dissect the scar out to even start the microtesy and the dissection. So the answer is again, no, there is no role for stem cells at this point on, for injecting into the testis for spermatogenic failure. Yes, one more comment.
One request.
Yes. Request.
In the forthcoming lectures, if you can touch upon do's and don'ts in regarding premature ejaculation or erectile dysfunction.
We have a case discussion on premature ejaculation, Dr. Ashish has.
Secondly, the role of oral available testosterones like Provironum with do's and don'ts as a general IVF specialist.
Okay. I think the don't is do not use oral testosterone as an IVF specialist. I think that is the only don't.
So the thing about oral testosterone is that unlike injectable, oral testosterone doesn't suppress the HPT axis. You get testosterone and deconoate available. There's a WHO study 30, 40 years ago on deconoate. And it's a very, very mild form, the oral form, and therefore it doesn't suppress the HPT axis. There's no real indication for it either. Provironum is a modified form of testosterone that cannot be aromatized to estradiol. And because it cannot be aromatized, it doesn't suppress the HPT axis. So mesterolone, which is the molecule in provironum, can be used empirically. There's no real rationale behind it. The theory is that it possibly acts upon the epididymis, improving function. Do I use it? Sometimes have I seen improvements, sometimes do I recommend it, sometimes. No, for erectile dysfunction, testosterone is a whole different thing. Provironum will not help, testosterone and deconoate will help occasionally if you have it with olive oil so it gets absorbed. Otherwise, the absorption is quite poor because it goes into lymphatics. It's a whole different story. I think we need to start the talk now. Is this on? Can I have the talk on reconstructive? Yeah, okay, it's gone. Go back, please. Back one slide. Yeah. So we know that if a man has sperm in the testes, we have two options. One is we can do some form of reconstructive surgery so that these sperm come out and result in a natural pregnancy, or we can extract the sperm from the epididymis or the testes very easily. I do it with a needle. Ranjit does a microsurgical epididymal recovery because he's been trained in the US and he can charge $5,000 for that. But when we do a PSA, it's over in 5 minutes, so the patient doesn't want to pay us that much. So the question is, which of these two, or do we ever do reconstructive surgery? Because most IVF people do not think of this. So I'm going to start with two real stories to drive home an important message, and then we'll address this further. This patient is in the armed forces. He's posted or was posted when he met me in the northeast of India. And this was a semen picture. Those of you who were paying attention yesterday would know low volume fructose negative. 95% of the times it's vasoplasia, but here the vasa are palpable. So this was a case of ejaculatory duct obstruction. In the northeast, he went to an IVF center. They said, no problem, we will do a TSA-ICSI. They did a TSA-ICSI. There was no pregnancy. The ... means his wife divorced him. She said, you have no sperm, you can't get me pregnant. I went through the pain of an IVF ICSI. It was really torture. I'm still not pregnant. They divorced. He got remarried, and that's when wiser sense prevailed, and he came all the way from there to Mumbai. And this is what we saw. Even if you've never seen a vasogram, you can appreciate that big dilated bulge at the bottom in the region of the prostate. This is a man with ejaculatory duct obstruction. very short surgery, a TUR, where an endoscope was put in the urethra, cut open the cyst, and 2 weeks later his sperm count was 60 million. I presume his wife was pregnant, the second wife. Now, if the IVF specialist had not rushed into IVF the first time, maybe his first marriage would have been saved. So it's important to realize that not all azoospermics automatically mean TISA, micro TISA, ICSI. Here is a second patient, and I'm going to read this, not because I want to gloat, I'm too old to gloat, but because there's a very important message in the last 2 lines. So he says, "Sir, I was a patient of azoospermia and I met you in December. You did a VEA, that's a vaso-epididymal anastomosis. We'll see what that is. In March, and 6 months later, my count was normal. Motility was 10%. At 8 months, it was 15%, and my wife is now pregnant. I'm really thankful for you. When I met you, you diagnosed, you told me it's okay. All the doctors in Mumbai suggested me IVF ICSI and told me VEA will not help. But you did it successfully, and this is the most important line. I really thank you from the bottom of my heart." What IVF specialists tend to forget is that when couples come to you, they come to you because they want to get pregnant, preferably naturally. When they accept IVF ICSI, it's their last resort because they feel nothing else will work. And very often, for the IVF specialist, azoospermia is a one-track mind. He has azoospermia, check the hormones. Hormones are normal or even a little elevated. Let's put in a needle, get sperm. But remember that for the couple, and even more so for the man, there's a huge personal investment and ego, a sense of completion if he's able to achieve a natural pregnancy. So the first message is that, remember, azoospermia is a spectrum. It's not just one single condition. And being able to achieve a natural pregnancy, if possible, can mean a lot for the man and for the couple. And therefore, it is important to distinguish before you jump into treatment as to is this obstructive or non-obstructive, and if it is obstructive, is it suitable for reconstruction? Because not all cases of obstructive azoospermia are good candidates for surgery. So in the next 10-15 minutes, we'll look at the different kinds of reconstructive surgeries, go on to identify the advantages and disadvantages of each of these procedures, and then summarize as to when you should refer a patient for reconstructive surgery and when IVF ICSI is the better option. So the first condition is where a man has normal spermatogenesis in the testes, but there's a block in the epididymis. This may be congenital. It may be acquired due to infection. When I was a DNB MCH resident, so that is like a long, long time ago, as they would say in Star Wars, we still used to see the post-smallpox patients. And smallpox very typically would create a block in the tail of the epididymis. So we had a large number of epididymal obstructions from smallpox. And in fact, one of the largest series on VA was published by Dr. Fadke, whom only the seniors here might remember. And they had a conventional VA success rate of 60%, because the smallpox block is localized right in the tail and there's a turgid epididymis above that. After that, we had a whole spate of STD-induced epididymal obstructions, but even those have become uncommon now. So there are fewer and fewer patients who need it, but there are patients. And in such a situation, it's possible to bypass the block by joining the vase to the epididymis. The problem is this epididymal tubule is very tiny. At the head, it's less than 0.1 to 0.2 millimeters, and even lower down, it is only 0.3 millimeters, even when dilated. So in the old days, before microsurgery, it was not possible to join the vase to the epididymis, and instead the surgeon would make a cut through the epididymis, through the fascia, into the tubule, slit open the vase, and then join the muscle of the vase not to the tubule, but to the fascia of the epididymis. So this was actually speaking not a true vaso-epididymal anastomosis, but more of a vaso-epididymal fistula where the two were brought into proximity. And obviously this technique had a relatively lower success rate, 20% in most hands, and therefore for most gynecologists the thought that VEA will never work and should not be advised. However, in 1978, Sherman Silber, who is a genius in his own right, though Ranjit is smirking because he knows other stories, came up with the concept of microsurgery. But he has done the first testicular transplant. There's an amazing book on TUR, the first concept of VEA. His book on microsurgery is a masterpiece, so he's done many things. And he has a beautiful lodge in Alaska, from where he sends me pictures that make me green with envy. So, after him came this other technique of microsurgery, which is the one most commonly used, where a single loop of the epididymal ductule can be isolated and joined to the vase. And this will be a true anastomosis because you're actually joining the mucosa of the vase to the epididymal ductule. And this is what it looks like at high magnification. It's a very, very technical and demanding procedure. So you can see the fat epididymal ductule, which is actually just 0.2 millimeters in size. Through a small window in the epididymis, this ductule is mobilized. A small side hole is made in the ductule. And then with 10-0 nylon, in my young days when I could see better, I used 11-0. With 10-0 nylon, you join this very delicate mucosa, which is stained blue of the vase, to the epididymal ductule, which is even more difficult to visualize. That's why I've put an arrow there, so that thin transparent ductule is joined to the epididymal, to the vasal mucosa. This technique has been modified now and made easier, but I'll show you the more difficult one to impress you. And with this technique, it is possible to actually get a far more precise anastomosis. Even then, it's not always successful. On an average, about 50–60% of the cases, but it varies depending on where we are doing the VEA. If you are right on the head of the epididymis, success rate is significantly lower, maybe 20–25%. If you are down on the body or tail where the ductule is larger, maybe 60%. And half of these men can go on to achieve a natural pregnancy. So with VEA, it is possible in selected cases. So how does this vaso-epididymal anastomosis compare to simple sperm aspiration and ICSI? If you look at cost, VEA in Mumbai, it's possible for free. One of my students has been trained, and at the public hospital he does VEAs, that's free. Nowhere is IVF free, and even in a private institution the cost is still affordable. Vineet charges more than me, but still it's affordable. Vineet was smirking, he's saying, Rupin, 60,000, where did you get that figure? But IVF is significantly more expensive. If the VEA succeeds, natural pregnancy, whereas ICSI still remains artificial, and for many people achieving a natural pregnancy, very important. ICSI needs to be repeated every time. VEA, once successful, should remain successful, though in about 10–20% cases, it can get blocked again. And of course, a VEA treats the problem which is in the male, whereas ICSI is punishing the woman for a problem in the male. So when you look at all of this, it would appear that VEA is in fact the better option in selected cases. So if we compare them, VEA is a safe surgery. You just cut the skin and the scrotum is there. So there's really no morbidity whether it succeeds or not. With IVF, of course, there's no surgery on the male, and there are some men who say, I don't want surgery. We see those too. Ranjit is nodding his head. He's encountering more and more chauvinists in the UAE. Though there's no surgery on the male, of course, it puts a major burden on the wife. A major disadvantage of the surgery is that it takes 3 months to 12 months for sperm to appear, then even longer for the counts to increase, and then for a pregnancy to take place. Whereas an IVF ICSI cycle is over in 2 weeks, and 2 weeks later you get to know the result. So time-wise, it's much faster. If the VEA is successful, it has a pregnancy rate roughly similar to IVF. I would say that IVF in good hands is still superior in terms of the pregnancy rate. VEA, as we saw, a lot less expensive. Second child is a bonus free if the VEA succeeds. And very important, if you're doing a vaso-epididymal anastomosis, at that time one can collect extra sperm, and because this is a case of normal spermatogenesis, freezing this is easy, and any good lab should be able to recover these sperm for IVF efficacy. So both things can happen simultaneously. So are there conditions where IVF efficacy is superior to VEA? As we said, VEA takes much longer for sperm to appear and for a pregnancy to take place. So if a couple is 35 plus, or there's a lot of social pressure, they are in a hurry, then IVF efficacy would be superior to reconstructive surgery. There are situations where the surgeon knows that VEA will have poor success. For example, if a man has had a hydrocele surgery, and because of that there is blockage, and we've seen a lot of such men, everything is badly stuck in those cases, and the success rate is very poor. If there has been hernia surgery which has damaged the epididymis or the vase, then again the success rate is very poor. If there is filariasis, again common in our country as a cause of obstruction, the epididymis is very edematous, and the VEA has a very low chance of success. And tuberculosis, again, a cause of obstruction, we spoke about it briefly yesterday. Reconstructive surgery will not work because there will be multiple blocks. So in all of these cases, ICSI is preferred. Also, if there is extensive damage of the epididymis and you're being forced to do the surgery right on the head, success rate is low, pregnancy rates even lower because those sperm are not very mature. And this can be decided by an experienced surgeon just by examining the epididymis, and he can say this man has a poor chance, this man has a good chance, and the ones where there's extensive damage, one may prefer IVF efficacy to a VEA. Lastly, and this is paradoxical, maybe in the city of Mumbai there are 2 or 3 people with sufficient training in microsurgery to be able to do a vaso-epididymal anastomosis. There are more than 200 IVF centers. So simple issue of availability. I think in Delhi it's only Vineet and Rajiv at AIIMS who are really trained and experienced in VEA. So there are very, very few surgeons able to do this, and that is one reason why often many of you, even if after this talk you want to refer your patient, may not be able to. So to summarize then, if we consider all the criteria of an effective therapy, in a young patient who has time, and has favorable anatomy, a vaso-epididymal anastomosis may actually be better. ICSI would be preferred if you've done it and it has failed, or if it's not suitable because of the various conditions we mentioned, or if the couple is aging and the wife's AMH is dropping and you don't want to wait 6 months or 1 year, or if there's a lot of social pressure, already 10 years have passed and now everybody is jumping on the couple and they have no time at all, their IVF efficacy may be better. So both are options, but for most IVF centers, the first option, that is surgery, is never, it is usually when a child dies and the couple comes because they want to have a child again. The patient's Ranjit seats in the UAE are expats living in the UAE. The man is now 55, married, divorced, and now he's married a beautiful East European. She is 35 and she wants all his money, and to make sure she gets it, she needs to get pregnant. And that's when Ranjit wants to do a vaso-vasal. So both are indications. Iatrogenic damage can happen due to hernia surgery and very difficult to treat. So in fact, if a man comes with a vasal block due to hernia surgery, I'm more inclined to advise IVF efficacy rather than reconstructive surgery. And if it's infective, again, it tends to be multiple blocks. Again, vaso-vasal, particularly for vasectomy reversal, is a microsurgical procedure. And with a high level of magnification, you can see how beautifully even the capillaries in the mucosa of the vase can be visualized. So this anastomosis is done either in 2 layers, mucosa to mucosa and then muscle to muscle, or if there's not much discrepancy, then you can do 1 layer. Now, this in good favorable cases, a vasectomy reversal should have a 90% patency rate. So that's a very high success. However, if the vasectomy was done on the convoluted vase, success rate drops. If there is marked discrepancy between the 2 ends of the vase, success rate drops. And if it's been a long time since the vasectomy, pressure accumulates in the vase. Because of that pressure, the epididymis swells up and then the epididymal ductule ruptures. And then there is a secondary block. There's a block at the vasectomy site and there's a block in the epididymis. And then we are doing a vaso-epididymal anastomosis even for reversing the vasectomy, and naturally then the success rate plummets. So the longer the duration since vasectomy, the greater is the likelihood of a back pressure block. But there's no rigid rule about it. I've done a vasectomy reversal 25 years after the vasectomy and there was still no block and we could do a simple vaso-vasal, and I've had people 3 years after their vasectomy where we had to do a vaso-epididymal. So here the surgeon will often decide if the epididymis is very turgid, it's more likely that there's a secondary block, the chance of success is lower, the reason for favoring IVF over a vaso-vasal increases. If the couple is older, often when they've lost a child, the couple may be in their 40s and now they're coming to you for reconstructive surgery. For them, it would be better to do an IVF ICSI. If the duration since vasectomy is very long and the epididymis is turgid, again it's going to be a vaso-epididymal, and there the success rate will be lower and we might prefer a sperm aspiration rather than reconstructive surgery. Again, like during VEA, if we do decide to do a vaso-vasal, at that same time we can freeze the sperm so that even while the couple is awaiting the outcome of the vaso-vasal, they have sperm to do IVF if required. And finally, we already spoke about this case where we can do a TUR, but not all ejaculatory ducts are the same and the obstruction is also varied. For example, we could have a large cystic block, which you see on the left, which was the X-ray that we saw, but we could also have a very fibrotic block. For example, if you look at the blue arrows here, the top arrow points at the vase, the middle arrow shows you the convoluted vase, and the lower arrow shows you that the vase ends abruptly. You do not see the seminal vesicle, you do not see the ejaculatory duct. This is the kind of fibrous ejaculatory duct block we see in men who have had genitourinary tuberculosis. So though this is an ejaculatory duct block, scanty ejaculate, fructose negative azoospermia, here we cannot do an endoscopic reconstruction, and this is a candidate for IVF ICSI. So in ejaculatory duct obstructions, if there is intraprostatic dilatation, either a large cyst or a dilated ejaculatory duct, then you must send the patient to the surgeon because this surgery is very easy. To the left, you can see a semen report of a patient in whom we did a resection just 3 weeks earlier. November 15th, we did the resection. The semen report is December 3, and his count is 71 million. So it's dramatic. When there's a favorable ejaculatory duct obstruction, the restoration of sperm counts is immediate, dramatic, and pregnancy very easy. But as I said, not all cases are suitable, and that is where your uroandrologist would take a call. So to summarize, the take-home message, these are very technical. We don't expect you or by and large even your uroandrologist to do it, but the take-home message is remember that even though you're ART specialists, bear in mind that couples would like, if possible, to have a child naturally, and every once in a while there are cases, azoospermic men, whose problem was a block which is correctable, and if you refer these patients for reconstructive surgery, that man will thank you.
Extremely sorry, we missed calling the chairpersons for this session. So can I please ask the chairpersons to come on the stage for a picture? Dr. Suparna Bhattacharya, Dr. Nivedita Shetty, Dr. Darshan Sureja, and Dr. Ashwini GB.
While they are
Can we
coming
have
up, any
the
questions?
chairpersons? And we can have the questions in the meanwhile.
I want to bring up a case that happened recently. In fact, I discussed it with you. And I want to bring out the points of importance with the way this case happened when it came to me. This is a patient that had undergone a TURED and got nothing out of that. So he came to me with the TURED, and it was done at a center where andrology is practiced regularly. And post-TURED, if you have an obstruction, like sir has shown, you should see sperms, and you almost see them immediately. Now, history taking. When I asked him, his volume was normal. I always will ask patients, do they have difficulty collecting a sample, especially if I'm looking at TURED as an option. And they should give me a history of low volume ejaculate. He did not give that history. When I examined him, he had an atrophic testes on one side, and I could not palpate the vas on the opposite side. So, to my mind, this was unilateral absence of vas deferens on one side and a atrophic testes with a normal vas on the opposite side. I began to prescribe him an ultrasound KUB. Can you tell me why I was advising him an ultrasound KUB? Anyone? Exactly. So I asked him, he says, I already know I have one kidney. I've been told by birth. Now, this was something which was probably not asked by the urologist that operated him, and he had unilateral renal agenesis. So it kind of just fitted with my physical examination, which we mentioned yesterday, was so important as a step, and we could have avoided a TURED surgery. In the end, I went and did a crossed VEA, which is a very difficult procedure. But just points that, and another thing, sorry, the truss findings. Sir, can you also comment on the truss findings that can be erroneous in case of TURED?
Cartoon, but the point Vineet is making is very important, that the diagnosis of ejaculatory duct obstruction is very tricky, and very often we've seen wrong diagnosis even by good, honest urologists, because they just don't understand this. So how much dilatation within the prostate can be identified will determine whether it can be treated or not. And very often, as he said, unilateral vasoplasia. In fact, it's tricky. Even when there is vasoplasia, in 15% of cases, there's a seminal vesicle-like structure visualized on ultrasound. That is because the primordial cells that form the seminal vesicle remain there and they form this cyst. And I've seen men with vasoplasia undergoing TURED just because that seminal vesicle looked bulky. So it's very important to diagnose it correctly.
So, one question. With regards to the actual causes of the block, we know if there is this ejaculatory obstruction, any surgical causes. But otherwise, we come back to the infective causes, which are the most commonest reasons for a block. But how do we actually decide these blocks? With the venogram, vasogram, can we actually find out? We can only find out one block. How do we know that there are no multiple blocks in the vas, or how do we decide to take up this case for a surgery? Because we don't know. We know that there is a block, but how do we take that decision?
So this is where, honestly speaking, experience counts. Knowing where is the block, how many blocks is a matter of history, examination, transrectal ultrasound, and an MRI. Despite that, sometimes there may be a double block, and we don't do a vasogram as a separate procedure anymore, but at the time of doing the surgery, if we cannulate the vas, we will aspirate fluid from the vas and check for sperm. If there's an epididymal block and an ejaculatory duct block, you won't get sperm in the vas. So now going by etiology, actually this is very technical, but very quickly. Etiology, tuberculosis, multiple blocks, we will not operate. Large cyst in the prostate, that's a congenital Mullerian duct remnant. Usually that is not associated with a double block. Simple de-roofing will help. Dilated ejaculatory duct but no cyst, this is infective. There we want to feel the epididymis. If the epididymis is turgid, probably a double block. If the epididymis is not turgid, only the vas is thickened, probably a single block. So These are variations that come with the clinical profile.
So technically in your group of patients who come to you, what percentage is the one you feel that surgery will help?
Okay, so if you look at Western literature, they only talk of the midline cysts which they can resect because they don't see infective. We see a fair number of infectives. So in our population, 60% are infective, not suitable for resection, 40% are correctable.
Thank you.
Yeah. So can I request Dr. Ashish Gude and Dr. Raghav Kasogi to join? We couldn't do it for the last session. So Dr. Ashish Gude. So we'll, and Dr. Moash, yeah. Now I would request Dr. Amit Patki sir to give a memento to, and Ranjit sir, to give.
We missed honoring Rupin last evening, so I would like to call Ranjit, please.